Hi there, everyone. Nice to be here. Thanks for inviting me, Avril. Sorry I couldn't come last year because it was actually my daughter's 4th birthday, and I'm sure some of you know you don't want to upset a 4-year-old, so apologies for that. Luckily this year it was a week ahead, so we're all good. And I think, are we just about in the morning? Anyway, maybe it's supposed to be good morning, ? So no one else has put disclosures, but quite a few of the places where you go and you see people giving presentations, they give disclosures. So I always feel a bit bad not including them. When I was doing an endocrine talk, I actually said I like cats and chocolate, and they found that quite amusing, but I've tried to be a bit more professional this time. So I'm employed by Auckland Hospital, and I also do PET-CT reporting at Mercy and nuclear medicine reporting as well, which seems to be picking up a bit over there. And I don't have any commercial financial interest in anything at all. So in terms of the content of my talk, I just wanted to introduce you to the concept of nuclear medicine. So I'm not sure how much this has been included in the previous years, as this is my first year attending this workshop, and then also just briefly touch on theranostics. And then we're going to come to some frequently asked questions about PRRT. So in terms of nuclear medicine, so what actually is it? So it's basically a subspecialty of medicine. It quite often falls under radiology. There's a strong imaging component. And essentially we use small amounts of radioactive substances, which we inject usually intravenously or sometimes orally if we're looking at the gastrointestinal tract. And it's generally for diagnosis of diseases and also treatment. So this image here just shows a patient lying supine, so lying on their back under what's called the gamma camera, which is what picks up the rays from the injected radioactive material that we've injected into the patient. And there's different substances we can inject if we want to look at the renal system, the neuroendocrine system, bones. We can bind the radioactivity to different substances, and it goes to different pathologies and different physiologies in the patient. So it really is kind of a way of looking at the function of the patient. And with the sort of introduction of hybrid imaging, so things like PET-CT in particular, but also SPECT-CT, which I'll come on to in a minute, we can combine the anatomy and the function of the different tissues. And because I'm dual trained in radiology and nuclear medicine, it means it's possible to interpret the different images. So in terms of the different scanners, so in Auckland Hospital we don't currently have any PET-CT scanners, unfortunately, but we do have 2 SPECT-CT scanners. So SPECT is our sort of standard way of how we detect these small amounts of radiation that we've injected. And in the old days, like the previous image, you just have one camera, but more these days you have two heads of the camera. And for example, in this position is how you'd look at the heart. So it's quite often used for looking at for myocardial studies. And you can separate the 2 heads, so you're looking sort of on the top and underneath. And you can pick up information from the front and the back of the patient that way. So some typical tests in nuclear medicine of diagnosis. Is that on the pointer? So for example here we're looking at parathyroid adenoma, so you can look at over-functioning parathyroid tissue, which you look for in a typical location here behind the thyroid gland. This is where you have the SPECT-CT imaging, the functional imaging combined with the CT imaging. In the top here we've got some thyroid imaging of the kidneys, which we quite often do in paediatrics particularly, and a bone scan, which people may or may not have come across before. And a more familiar type of the nuclear medicine or radiology scanner is a PET-CT scanner, which you can see here, where you have the CT and the gamma camera part of it, or the part that picks up the positrons, all combined together. And this is the sort of typical images that we get with PET-CT here. So in terms of who works in a nuclear medicine department, I've included this picture here of the Eden project, not just because I've spent the last few weeks, fortunately, happily wandering around Kew Gardens with my family in the UK, but just to show it's like an ecosystem. So we all sort of work collaboratively together. So the technologists, which we have majority of in the department. They actually do most of the work really in the nuclear medicine department. They prepare the isotopes, they do all the quality control in the hot lab, on the scanners. In our department, they also inject the patients, they do the scans, they do all the processing. It's a huge amount of work that they do. We currently don't actually have any nuclear medicine nurses, so that's something that we're working on towards this process. Most departments also have a radiopharmacist or radiochemist, but in our department, the technologists do that role as well. Medical physics, well, there's quite a strong medical physics department in Auckland Hospital, and we've got some input into the ADHD department. Often you'll have booking clerks and receptionists. So, for example, with it being a functional imaging test, that you have to consider drug interactions, and there's each protocol has got a different set of instructions that can get a little bit complicated. And then, obviously, the nuclear medicine consultants as well, and we probably have the easy job compared to everybody else. And then often we have trainees, so we have radiology trainees coming through all the time, as well as the technologist trainees, medical physics, etc. So in terms of treatment, so the other side of nuclear medicine is the treatments, and there are quite a few different treatments that happen with nuclear medicine. So in ADHD currently we do treatments of the benign and malignant thyroid conditions, but it comes under the endocrine specialty, and we do the follow-up imaging for those currently. There's also treatments for synovitis in the joints, patients that have haemophilia or other conditions. You can treat painful bone lesions with certain substances like strontium, and PRRT as well obviously comes in the list of the nuclear medicine treatments. So in terms of PRRT, it stands for peptide receptor radionuclide therapy. It's a radioisotope therapy which is injected into the bloodstream. And essentially it's low doses of internal radiation treatment which are very specific to the neuroendocrine cells. And that's due to the overexpression of the somatostatin receptor. And we'll come on to that a bit more later on. And then the second concept, theranostics, which you may or may not have come across. This is where you have the diagnostic and the therapeutic capabilities of a single agent for imaging and treatment of particular diseases. So, for example, thyroid cancer is sort of the sort of most long-standing form of this, where original imaging is with iodine-121, which is a specific type of radioactive material, and then it's followed on with treatment with iodine-131. So in the context of neuroendocrine treatments, and I'm sure many of you are familiar with this concept already, is a diagnosis is through a PET-CT using the gallium-68 dotatate, so that's the GAT8 PET that's been referred to. And in this example you can see here there's uptake here in the pancreas under the liver. There's the GAT8, the gallium imaging on these two slides, and then the treatment with the lutetium-177 dotatate, and this is the SPECT-CT afterwards showing where the uptake of the treatment has gone to, replicating the gallium-68 PET-CT scan. So just to go through some frequently asked questions for PRRT, and apologies if this is replication or duplication from previous years of sessions. So the main goals are provide the symptom relief, it can stop or slow progression of disease, and can contribute towards improvement of quality of life. And the main conditions are the gastroenteric, pancreatic, neuroendocrine, tumours arising from the stomach, small intestine or pancreas. So in terms of which conditions, so it tends to be the more advanced conditions or where there's progression. Even, for example, on other treatments, it can be used as a second-line treatment, and they must be positive on the somatostatin receptor imaging, which is a gallium PET-CT imaging. It may also be when surgery is not recommended, for example, the disease is perhaps in too many places, and if there are symptoms which aren't responding to other medical therapies, it can also be used. So in terms of how do the treatments work, In America, where it's been recently approved by the FDA about a year ago, and also in Europe and in Australia as well, they generally recommend 4 treatments spread about 2 months apart, so about 8 to 10 weeks apart. And depending on sort of the local protocols and the different hospitals and various other factors, it may be a combination of the 90 yttrium, which is the same as the CERT treatment, which Menina referred to before, or the 177 lutetium. They're both similar types of treatment. And other local protocols, which could include whether it's an outpatient protocol, which tends to be the most common protocol in many centres around the world, or possibly inpatient-based treatments, for example, if you're worried about exacerbating a carcinoid sort of syndrome and various symptoms like that. It can also depend on different factors, if you're elderly, if you've got some mobility, reduced mobility, and all of those sorts of things. So in terms of how is the PRRT process performed, so you'd start with some pre-medications, including ondansetron or other anti-nausea medications. Important factor is the amino acid solution, which is infused over 4 hours into the bloodstream. And one of the things I've actually found in this process is there's no commercially available amino acid solution available in New Zealand, so it would involve sort of commissioning and manufacture of the amino acid solution specifically for this process, and that's obviously a really key part for protecting the kidneys. And after about 30 minutes after the amino acid infusion starts, then the PRRT treatment starts by an infusion, and that takes about 30 minutes, and then another 3 hours of the amino acid infusion carries on until the end. So after the treatment, most centres would also perform a SPECT-CT scan just to make sure the treatment has gone to the places you'd expect. So similar to the other images previously, this just shows the uptake here in this area. You can do various calculations as well from that. And in terms of what are the side effects, is it a safe treatment? So all treatments do have some risks and benefits, and that would depend on discussions with your specialists and personal history, MDM discussion, and all of those sorts of things. It's generally quite well tolerated, and the side effects can be short or long term, or possibly delayed. And this all forms part of a consent process, so patients that have had PRRT, I'm sure, are familiar with some of these things, either perhaps experienced yourself or certainly discussed during the consent process. So things like nausea and vomiting, and often they say that's from the amino acid infusion itself, and that's why the pre-medication is so important. Some places also give a steroid a tablet as a pre-medication as well. For example, in Peter MacCallum Hospital, can experience some abdominal pain. Long-term side effects can include reduction of the blood cell counts, which is why it's so important to keep track of the blood tests and the blood counts. And there can be some delayed effects, which are very rare, including the kidney damage, which is hopefully reduced by the amino acid infusion. And occasionally you can have development of a second hematological condition of the bones. Post-treatment, so the nuclear medicine department would generally provide instructions around radiation safety. That's a routine part of work of nuclear medicine department. But it's things like how to, staying a safe distance away from others, and particularly care around the bathroom hygiene. And regular blood tests would then be recommended, something between 2 and 4 weeks, which would then be reviewed by the nuclear medicine doctors and the oncologist, and that would help to decide whether how the body's responded to the treatment. Is the kidney function and the platelets all okay for doing the next round of the treatment? So hopefully, just to wrap up, we've given a brief overview of the background and the process around PRRT